Welcome back to part 80 of our Decode Healthcare Explainer series. I'm Harshal, and today we are absolutely laser-focused on Chapter 12 of the ICD-10-CM official guidelines, which covers diseases of the skin. Now, if you've ever dealt with the complete nightmare of claim denials for wound care or pressure ulcers, well, I've got some great news for you. Mastering these specific guidelines is literally your golden ticket to getting paid. So let's just dive right in and decode these dense coding laws into some easy, dynamic concepts, all right? Okay, let's lay out our mental roadmap for today. We're unpacking 6 distinct categories. First, Chapter 12 Skin Foundations. Then, the Pressure Ulcer Staging Matrix. Third, the Non-Physician Exception. Fourth, Unstageable versus Deep Tissue Injuries. Fifth, Ulcer Progression During Admission. And finally, Non-Pressure Chronic Ulcers.
All right, starting us off, Section 1, Chapter 12, Skin Foundations. Before we even think about looking at a single L code, we have to establish the absolute, rock-solid CMS law for this entire chapter. You code exactly what is documented. That's it. Coding is an exact science, right? It's not some guessing game based on clinical assumptions. So if the provider doesn't explicitly write it down in the medical record, well, it simply doesn't exist for your claim. Period.
Moving right along to Section 2, Pressure Ulcer Staging and the category L89 Matrix.
Now this brilliantly illustrates how pressure ulcers work. They happen from decreased circulation, usually over bony projections in patients who are restricted to a bed. Because they can range from just a superficial red spot all the way to massive tissue destruction, the clinical depth dictates your numerical stage. So, Stage 1, that's your red intact skin. Stage 2 is partial skin loss. Stage 3 is full thickness loss, going all the way down to the fascia, that connective tissue enclosing the muscles. And Stage 4 is extensive destruction down to muscle or bone. So, for example, a Stage 3 sacral ulcer maps directly to an L89153 code. Makes sense, right?
But to actually build that complete L89 code, you absolutely need 3 mandatory puzzle pieces straight from the documentation. You need the exact anatomical site, the laterality, meaning right, left, or unspecified, and the specific numerical stage we literally just covered. Miss even one of these, your code is incomplete. And incomplete usually means an automatic denial. Okay, let's hit Section 3, the non-physician exception. Now, what's really interesting here is this massive, highly specific exception to that golden rule we just talked about. Every single coder needs to memorize this. The official guidelines state the associated diagnosis must be documented by the patient's provider. So, what does this actually mean for us? Well, it means a wound care nurse can legally document the physical depth and stage of the ulcer. But, and this is a huge but, the attending physician must explicitly confirm that the ulcer actually exists. If the nurse says Stage 3, but the doctor's notes are completely silent, you can't just code it. You have to query the provider. All right, Section 4, Unstageable versus Deep Tissue Category L89 Differences. Let's clear up some major confusion between 2 terms that describe severe damage. Unstageable uses a 0.4 code, like L89-4. This literally means you cannot physically see the bottom of the ulcer to stage it, simply because it's completely covered by eschar, which is that dead, dark, crusty tissue, or slough. On the flip side, deep tissue injury uses a 0.6 code. This is a persistent, non-blanchable deep red, maroon, or purple discoloration. So here's the zero fluff rule to remember. Crusty eschar means unstageable. Deep maroon discoloration means deep tissue injury. So what exactly happens when a surgeon intervenes on that unstageable ulcer? Well, enter the debridement rule. If the true stage is revealed after they surgically remove that dead tissue, you assign only the code for the newly revealed stage. Meaning, if scraping away the eschar reveals a Stage 3 ulcer underneath, you just code the Stage 3. You actually drop the unstageable code entirely for that specific encounter. Next up, Section 5, Ulcer Progression During Admission. So, the crucial point here is, imagine a patient is admitted, but despite getting great care, their ulcer actually deteriorates during their stay. How do you stack that claim? Well, the guidelines mandate a 2-code sequence. Step 1, or slot 1, is coding the site and stage on admission. Step 2, or slot 2, is coding the highest stage reported during the stay. So if they arrive with a Stage 1 and it progresses into a Stage 3, slot 1 gets the Stage 1 code and slot 2 gets the Stage 3 code. You have to tell the entire story of that clinical progression. But what about ulcers that are actually healing? Here are your hard and fast rules. Healed on admission? Do not code it at all. Described as healing? Just assign the stage based on the documented depth. And what if it was present on admission but completely healed at discharge? Simply assign the code for the stage it was at when they first walked through the hospital doors.
Finally, Section 6, non-pressure ulcers in categories L97 and L98.
Okay, we're stepping out of category L89 now. Non-pressure ulcers are fundamentally different because they result from underlying conditions. Think diabetes, vascular insufficiencies, or post-thrombotic syndrome, not localized physical pressure. So to properly code from category L97, you absolutely must extract three things from the medical record: the underlying cause, the laterality, and the exact severity level. Notice how these aren't staged 1 through 4 anymore? Here, you're looking for explicit words like a break in the skin or exposure of fat, muscle, or bone.
Let's see how this builds, because there is a mandatory etiology sequencing law for these non-pressure ulcers. You always have to code the underlying condition first. For example, slot 1 gets E11.621 for type 2 diabetes with a foot ulcer. Then and only then, in slot 2, do you drop in the L97 ulcer depth, like L97.512 for a non-pressure ulcer of the right foot with fat layer exposure. Remember, the ulcer code is always sequenced secondary to the disease that caused it.
And to perfectly tie this whole shebang together, the progression logic is wonderfully consistent. Just like we saw with pressure ulcers, if a non-pressure ulcer progresses to a higher severity level while they're admitted, you must assign two codes, one for the admission severity and a second for the highest severity reported.
Which brings us to the end of Chapter 12. Remember our golden rule for today: code exactly what is documented. Thank you so much for joining me for Part 80 of this Decode Healthcare Explainer. I really hope these breakdowns help you build flawless, denial-free claims going forward. But hey, before I let you go, a quick question to chew on. Are you ready to tackle the total nightmare of pathological fractures, osteoporosis, and the super complex rules of active versus subsequent care? Join me in Part 81 as we decode the musculoskeletal system. See you there!